Thank you. Next slide, please. We have a full roster of very impressive and wonderful speakers. So these, you will find their biographies in the handouts that are available. Next slide, please. The agenda for today, we will hear first from Chris Perrone from the California Healthcare Foundation, followed next by Ginger Moyles, who is going to provide a patient caregiver perspective. I'll then give a very brief policy overview of where we are in California with telehealth policy, and then we'll have a panel moderated by Dr. Humphreys from UC Davis and staffed by Dr. Goldwyn, Dr. Anaya, and Dr. Stoll. And then we'll have answers, a Q&A session towards the end of about 15 to 20 minutes. Right now, I'll hand it over to Chris Perrone from the California Healthcare Foundation.
Thanks, May, and good morning, everyone. I am Chris Perrone, Director of Improving Access to Care at the California Healthcare Foundation, and I'm delighted to also welcome you to today's briefing on telehealth. As many of you know, the California Healthcare Foundation is dedicated to advancing meaningful and measurable improvements in the way the healthcare delivery system provides care to the people of California, particularly those with low incomes. And at the California Healthcare Foundation, we have long held the belief that telehealth can be an important tool in transforming California's healthcare system, particularly for Medi-Cal enrollees and patients who face extra barriers to accessing care. Those who live in rural areas far from the nearest available doctor, those who are challenged by the difficulty finding child and elder care, or the loss of pay when they have to take a full or half day off work for a visit with their doctor due to lack of reliable and timely transportation. Despite the enormous potential of telehealth, however, progress has been slow, and coverage for telehealth through Medi-Cal was much more restrictive than what's typically available to those with private insurance. Well, what a difference a year makes. Who would have imagined that when we gathered for this briefing last year, telehealth would become such an essential part of our healthcare system, integral to how Californians get their care. When the pandemic hit, California healthcare providers, including those in our safety net, moved quickly to adopt telehealth, retrained and retooled their staff, began adapting their workflows and educating patients, and found creative ways to help patients who are challenged by technology barriers to connect by phone and video. As a result, most have been able to continue to care for patients and generate enough revenue to keep their practices open. Perhaps it is not surprising then that in a survey of Californians from CHCF and NORC to be released this week, 62% of respondents who received care during the pandemic reported that they had received a telehealth visit, including 65% of respondents with incomes below 200% of the federal poverty level. And for the large majority of those with a telehealth visit, their experience was positive, with most reporting that they were equally or more satisfied with their telehealth visit than with their last in-person visit. Remarkably, levels of satisfaction with phone and video visits were even higher among Californians with low incomes than they were for respondents overall. The challenges before us are very different this year than they were a year ago. The challenge we face now is to ensure that telehealth is benefiting all Californians, that those with digital or other barriers are not left behind, and that telehealth becomes a seamless part of how we provide care, available to patients to utilize when and where it improves access to care and health outcomes. These ongoing challenges are one reason that the CHCF Board of Directors committed $6.5 million over the next year to ensure that all Californians benefit from telehealth. A cornerstone of this investment is the Connected Care Accelerator, with grants to over 50 safety net practices to build and expand their telehealth capacity, and a learning collaborative to support rapid testing of ideas for improvement and dissemination of successful approaches. We are also supporting educational efforts by the California Medical Association, the California Primary Care Association, and the California Telehealth Policy Coalition, in an evaluation of the experience of California's healthcare safety net with telehealth by RAND. As social restrictions imposed due to the pandemic are lifted, it's important to remember why telehealth must continue to be an essential part of how Californians get their care. That 7 million Californians currently live in a health professional shortage area, that Medi-Cal enrollees rely on the emergency room as their usual source of care at nearly 3 times the rate as those with employer-sponsored insurance, and that 1 in 4 Medi-Cal enrollees has difficulty finding specialty care, a rate 2 times greater than for those with employer-sponsored insurance. By now, it should be clear to all of us that telehealth can play a life-saving role in closing the gap between people who need care and those who are able to receive it, thereby addressing the deep and long-standing disparities in health and healthcare. I look forward to sharing more as a participant in today's webinar, and especially to hearing from today's panelists who will speak to these issues. It's my pleasure now to turn things over to Ginger Moyles, as May mentioned, a parent who lives in Northern California, who, like many people in California, face long distances to travel to the nearest provider for them and their children. Ginger's unique perspective as a parent and grandparent, including with a child with special needs, is one that we all benefit from hearing from, and I look forward to hearing from Ginger. Off to you, Ginger.
Thank you. Hello. I live right up by the Oregon border in Siskiyou County. My daughter was diagnosed in 2011 with Spritz-Goldberg syndrome. She was adopted out of foster care. I was a single parent when I adopted her, and I've done all of her medical care by myself until just a couple years ago when I got married again. It is 4.5 hours one way for me to drive to UC Davis with no stops. If you have a medically complex child, you are not driving that with no stops. So it is an all-day drive to go down to Sacramento. For sometimes a 5 to 15-minute appointment is a minimum of a 12-hour day for me to go down and come home. Due to her behaviors and her fear of doctors, because this has been a lifelong lifestyle for her, she is not always compliant when we get to the doctors. She is often under the table, kicking, screaming. Appointments are very difficult. The doctors seldom actually get a hands-on. Due to her syndrome, most of her issues are internal. She does lots of x-rays, MRIs, CT scans. The hands-on tests are typically diagnostic, and then our doctor's appointments are how to manage that and to get the results of those. Those results can be done via telehealth, over the phone. It saves a lot of time for me to come down, get the tests, and then manage that by telehealth after I get home, and how we're going to do that. They've already have the tests in front of them. My first experience with telehealth was started in 2018. I had one doctor at UC Davis that utilized telehealth prior to COVID-19, and that was wonderful. We started with every other visit. He would see us in person, and then we would do one telehealth. Typically that every other visit was great because it landed in the wintertime. I didn't have to drive the mountains in the snow. And then when the weather was cleared up, we'd do an in-person visit. Since then, we have had 9 telehealth appointments with that doctor. This year, since COVID hit, we have had 3 in-person doctor's appointments, and those were for her x-rays, MRIs, CT scans done at UC Davis. Everything else since then we have been able to do by telehealth, which has saved a ton for everybody. She had 1 COVID test done in person, but we have had 10 telehealth visits with UC Davis since then. And just this morning, I was able to change one that I have tomorrow down there at 9:30 in the morning, which saves me at least 5 hours driving down there that I can now do by telehealth. Before this, telehealth was a dream for me as a parent of a medically complex child. It saves me time and money to not drive down there. My biggest fear is this going away after COVID-19. Because she's adopted out of foster care and she's a medically complex case, she is under a managed medical care system, and I really need this to stay. I live in a very rural area. One of our big problems is with some of the parents up here that I've advocated and helped for is the ability to travel that far, reliable transportation. And then there's a connectivity issue being in a rural area with either having access to internet or even having a reliable internet connection out here. It would be great if some of these calls could be done by just telephone in between the hands-on visits, that could be reimbursed and covered. I know it's an issue for the doctors too. I think they should be reimbursed. for the time and the effort that they put into giving us the information that we so appreciate being able to get. The only other problem that I have had living in a rural area is the reimbursement rates for Medi-Cal being so low that it's hard to get providers to even want to come work in these rural areas. We have to travel for specialty care. There isn't anything in this area. The reimbursement rates are just very low for Medi-Cal, managed Medi-Cal patient coverage. That would be great if that could change. We'd have more access to care closer. We wouldn't have to travel so far. But as far as telehealth goes, after COVID-19, it would still save me. I know there are parents up here that are enjoying it. I don't know how we lived without it. It saves me so much time. When I average at least 25 appointments a year to Sacramento, it is amazing to not have to travel to every single one. It has limited me out of 13 appointments to only have to travel to 3. I don't know how to say thank you. And I would like to be able to continue this as a parent in a rural area, to continue being able to see great providers at UC Davis. My best friend goes to UCSF and has been able to do telehealth also, and we so appreciate it. And I thank you for your time, and I would love you to consider continuing this for private care and for managed Medi-Cal cases also. Thank you for your time. I need to turn this back over to Chris again.
Great, thanks, Ginger. Thanks for so much for sharing your story. It's stories like yours that really, I think, bring home the important role, both the challenges that you as parents and caregivers face with our healthcare system, particularly in Medi-Cal, and really bring home the benefits of telehealth. So I'm going to introduce now Misty Humphreys, who is going to be our moderator for today's panel, but first introduced May. Misty is associate professor in the Department of Surgery at UC Davis Health. She specializes in open vascular and advanced endovascular treatment for arterial and venous disease. She is a leader in health outcomes research and is currently researching how telehealth can be expanded to treat patients with vascular conditions. I must say that when I think of telehealth, the first things we know in terms of use cases are primary care, mental health, endocrinology, dermatology, not vascular disease. So I think it's really terrific that that Dr. Humphreys is doing this work and is really extending the reach of telehealth in terms of the practice of clinical medicine. So Dr. Humphreys, over to you.
Well, thank you very much. About a year ago, I was attending a telemedicine summit, and there was a woman who was speaking, and I had no idea who she was, but she was talking about this amazing coalition and all the work that they were doing, and really how they were trying to expand telemedicine. And I wrote down this woman's name, and then later on I emailed her and said, I'd love to help out with this. I'm not sure exactly what it is. And that person was actually May Kwong. She's an exceptional speaker. She is very passionate about telemedicine and really leading the coalition. And so I am thrilled to have her speak and really kind of give us a policy overview about that. May?
Thank you, Dr. Humphreys, for that very nice introduction. I have a PowerPoint here, so we'll go to the next slide. First off, I have to have disclaimers. Any information provided today is not to be considered legal advice. It's strictly for informational purpose. Please always consult with legal counsel if you want a formal legal opinion. And also know if I happen to mention a company or show some sort of product, neither I nor CCHP has any type of financial interest, arrangement, or affiliation with such a company. Next slide, please. I mentioned that we are the convener for the California Telehealth Policy Coalition, but we also act as the federally designated National Telehealth Policy Resource Center. We do that through a grant from HRSA, and what that means is we provide technical assistance to basically anybody who has a question around telehealth policy. So we have helped people all the way from the White House and congressional members to state legislators, to health systems, to providers, and more frequently what we're seeing now with COVID are consumers who are asking about telehealth. and how they can access it, what is it, and how can it help them during this particular time. Next slide, please. So for most people, when they think of telehealth policy, they think about reimbursement, what is covered, how do I get paid? But really telehealth policy touches a spectrum of different types of policy issues. We're talking about provider practice and consumer protection, and also supporting providers in their work, such as providing telehealth training and medical education, sharing best practices. So it's not really just about billing and coverage and reimbursement. It really spans the spectrum of like how you receive healthcare and how do you receive health education as well. Next slide, please. However, a lot of our existing telehealth specific policies, both on the federal and state level, really do just address the reimbursement side of things, even though there are other policy issues that telehealth touches that need to be addressed. A lot of what we have as established policy that's specific to telehealth is related to reimbursement. Now, when COVID hit, a lot of us saw a lot of changes that were going on the federal level related to Medicare, because that's where a lot of the telehealth policy pre-COVID-19 exists. It's around Medicare, what it covers, what it pays for. And it was pretty limited on the federal level. And the reason for that is because a lot of that is in federal law. So there's only so much the Center for Medicare and Medicaid Services can do as far as the policy is concerned. They have to wait for Congress to act. And really, Congress has not done a lot of major changes to telehealth policy on the federal level for a lot of years. So what you had going into COVID on the federal level with Medicare were some pretty antiquated, very limiting policies. So you saw the feds having to do a lot of changes. If you compare what the Medicare policy was to state policies in Medicaid and with commercial payers, it was pretty far behind. So they had to do a lot more work than maybe some of the states had to do. Some of the changes that they made were really basically around where the patient was located and how you can deliver services. So they removed these restrictions that they had on where the patient was located. And for Medicare, that meant they had to be in a rural area, and that was very specifically defined. And also they could only be in certain types of facilities, like a doctor's office or a hospital. Well, when COVID hit, not a lot of people were going into hospitals or doctor's offices for the regular appointments. They were staying at home, or they were ordered to because of stay-at-home orders. So Medicare had to adjust that policy, and they had to wait for Congress to allow them to do that. Also, Medicare limited the types of providers who could provide services. It was like a very short list. It was only about 10 different types of providers, like doctors and midwives and dietitians. They had to expand that list as well because, again, people needed to receive services, and they weren't just limited to like those types of providers. They were receiving like all types of health services. And also, speaking of services, Medicare had like a limited list of services on what they would reimburse if you provided via telehealth. So they had to increase what were eligible service that they would cover if telehealth was used. They went from a list about 100 eligible codes to 240 eligible codes during COVID-19. Next slide, please. So what was going on in California, though? Well, California actually was one of those states that had a better, more progressive policy around telehealth pre-COVID-19 than what we saw in Medicare. So Medi-Cal, the California Medicaid program, actually updated their policies and expanded them the year before in the summer of 2019. And what they did was that they said that, we'll cover all the services if it's delivered via telehealth, either through store and forward or live video, as long as it's a service that the Medi-Cal program covers, as long as it doesn't require some sort of in-person service. So we'll go ahead and do that. So that was definitely like a more progressive policy than what you saw on the federal level. They also didn't limit the location. They said like, well, it could take place basically anywhere, and that included the patient's home. And for the provider, they said whoever's like a Medi-Cal enrolled provider can use it. They did still have some limitations. So for example, I said that they could provide the services via store and forward and live video. They did not cover remote patient monitoring, although they did allow at least some e-consult. But as far as providers are concerned, they said like all providers can do this, but they did have limitations on federally qualified health centers and rural health clinics on what they can do as well. So while it was sort of more expansive than what the feds did, there were still limitations that California had on their telehealth policies before COVID-19. Also, what was happening in California during last year, AB 744, which required payment parity for commercial health plans and all insurers, that was just passed like right before COVID hit. However, it does not kick in, or as far as the bill is concerned, the legislation, it would not kick in until January 1st of 2021. So in a better position than what the feds were, than what a lot of other states were. California's telehealth policy going into COVID was not that bad, but still they even had to make some changes too, or we had to make some changes as well. Next slide, please. So what were some of the changes? Well, again, it was to like fill those gaps of what they were doing. Really, a lot of it was around what federally qualified health centers and rural health centers had to do. They waived the restrictions that they had on there before COVID-19. So they were able to use telehealth a little bit more with a little more flexibility. One of the big things that was done, and this was done on the federal level as well, was allowing audio-only phone. Now, before COVID-19, a lot of places, not just California, but a lot of places didn't really regard phone as part of telehealth. They usually had like explicit exceptions saying like telehealth is defined this way, and that excludes phone, email, and fax. But policymakers recognizing that not everybody would have access to telehealth technology for whatever reason, broadband, not having access to the equipment like laptop or a cell phone, they still needed to receive services. So audio only phone was included both in the Medicare policies and a lot of Medicaid policies as well. And that was what was allowed in Medi-Cal. That was one of the big changes that Medi-Cal made in the face of COVID-19. Next slide, please. So what has been the impact of some of those changes? So this is data in Medicare for fee-for-service beneficiaries. And you can see, not surprisingly, like the number of weekly visits dropped that are in person, and the weekly visits for telehealth picked up. They basically did half. They compensated for like half of what you would normally see for like the primary care visits. So that was in reaction to like the more expanded Medicare policies, and also like the fact that people were limiting their contact and limiting their visits to the doctor's office in-person visits. Next slide, please. Now, I wasn't able to find any data specific to California, so this does encompass other states. So comparing data from June of 2019 to June of 2020, you even see the amount of telehealth visits for conditions change. Before and even after, the top sort of like specialty telehealth was used for were mental health conditions. But what we were seeing were some of the other conditions were switching out. So for acute respiratory disease and infections was a little bit higher in 2019. Still there, at least exposure to communicable diseases, not surprisingly, that like made an appearance in June 2020. Urinary tract infections were another sort of high utilizer in June of 2019. But you had like joint and soft tissue disease and issues. That was a different one replacing it in June of 2020. So you see the shift as far as like compared to last year to this year and what telehealth is being used for. Next slide, please. And you also see the usage claims as far as compared to 2019 shift as well. Now, compared to June of 2019 to June of 2020, basically you see like a 3,500% increase in telehealth usage. Again, not surprising. We had to shift. We moved from in-person to telehealth to reduce exposure and infection, and also the policies became a lot broader. What's a little bit more interesting is the urban-rural usage in comparison. Actually, quite a high number of urban usage in both June of 2020 and June of 2019. 2021, probably not as surprising. In the early days of COVID, definitely we saw more cases in urban areas than we saw in rural areas, but it also speaks to like the policy allowing them to utilize that in urban areas as well. Next slide, please. So a little bit more California specific information. This is a map of telehealth utilization and by community health clinics, so FQHCs, and how much telehealth they have used. So this is a snapshot of September 11, 2020, and see California, they're in one of the states that had their community health centers were one of the ones that had like high utilization of telehealth. Again, probably not surprising just because of the policy situation in California was a little bit better for FQHCs to utilize telehealth, but it's interesting to compare it to the rest of the country. So it's around 56% if you go by the bar of like how many telehealth visits for community health centers took place that week. It was about 56% for that particular snapshot. A little bit of a caveat for the data though, this is the volunteer data, so you may not have a consistency of who's reporting that. You may have sort of a high volume clinic reporting 1 week, but maybe not reporting for like several weeks. So it is, take it with a bit of a grain of salt, but it gives you at least kind of an idea of how much FQHCs are utilizing telehealth in California. Next slide, please. So what are other issues? I said like telehealth policy extends across different issues, not just around reimbursement. We have broadband licensing, education of providers and consumers, out-of-date forms and regulations. So there's like a lot of forms and regulations that are in Medi-Cal that are with like commercial payers that didn't really take into fact telehealth when was being used. So they're a little bit out of date, protocols that need to be changed. All of these are things that impact the utilization of telehealth and really became apparent during COVID-19. Next slide, please. So where do we stand now? Everything is still temporary. Those temporary changes that were made in reaction to COVID, they're still temporary. We know the public health emergency, which a lot of these changes are tied to, was renewed last Friday. So we're good through like January 30th. But they are still temporary. So this question of like, what happens now? What if it suddenly gets cut off? What happens to all the patients? What happens to all the providers? And right now, we're not quite sure. Policymakers in California are still thinking about that. There was no significant telehealth legislation that was signed this year. And the two pieces of legislation related to telehealth that did get to the governor's desk were vetoed. And he had in one of his veto message that DHCS is currently looking at evaluating what their telehealth policies are and which one of the temporary flexibilities that they will be keeping. Next slide, please. So here are a couple of policy changes that the coalition is recommending that we definitely look into. A lot of these, again, we're keeping some of the temporary changes, definitely those around that impact FQHCs and RHCs, but also some of the things that were not addressed during COVID-19, such as including remote patient monitoring as an eligible way of like providing services underneath the Medi-Cal program, and also creating more provider education materials and patient education materials and having that available. Next slide, please. So these are a couple of CCHP resources that we have. You guys will have access to the slides, so don't worry about trying to copy down the link. But I think it is time for me to turn this back over to Dr. Humphries. Thank you.
Well, thank you. I think that was a wonderful overview of where we are, where we need to go. And so now we're going to hear from 3 different speakers, each bringing a unique perspective. Our first speaker is an HIV specialist and medical director of the Mendocino Coast Clinics. Dr. Lawrence Golden, I ask you to come and just tell us a little bit about your experience with telemedicine and telehealth so far.
Good morning. Thanks for having me here. I'm the medical director of a federally qualified health center. We're based in Fort Bragg, California. Our range is about 50 miles of service, is 50 miles on the coast and 20 miles inland. We take care of 11,000 patients. So first I want to talk briefly about the reality of what we're dealing with now. I'm going to talk a little bit about the access issue because I think it is fundamental to this problem. And I want to speak briefly about the financial piece of this. I'm on the medical end, not the administrative end. So my understanding of the finances is somewhat limited, but I'll do the best I can. So the reality of what we're living with now is that 80 to 90% of all my visits, in fact, most of my providers are either done, they are done virtually, either by telephone or video. We prefer to do them by video, but given our rural situation and the quality of video access being as limited as it is, we waste a lot of time trying to make a good video connection and end up doing it by telephone. Most of my providers are over 50 years old. There are 11 of us, 4 of us are over 60, myself included. 3 of my providers currently refuse to see patients in person. This is a negotiated issue. It's a complicated issue around COVID, but it is certainly an understandable one. This, at the moment, of course, makes virtual communication imperative. This is going to change, of course. Given the current finances of running a clinic like ours or most other clinics, if we do not continue to have the kind of financial support we're getting for virtual encounters, we will have to close our doors. So what we are currently doing, we are trying to negotiate our way between opening our doors to our patients and then anticipating what's going to happen to us or to the clinic when we do so. If you have any doubt, I won't go into the details about how there has been such a change in patient feelings about virtual visits. That's been done very nicely by Mr. Perrone. But I would suggest do what I did the other day, which is do a web search about with the phrase virtual medicine is here to stay. You will find an enormous number of articles, both in peer-reviewed journals, non-peer review, and various medical administrative journals and newspapers. I don't think there's any doubt that the public believes that this is here to stay, and I think for very good reason. Let me also turn a little bit to access. As I said, we cover 11,000 patients at our clinic. And currently, we have a difficult time recruiting, as most rural clinics do. The current average wait for the next available visit for our patients is more than 2 months. Mine is currently, for a routine visit, is 4 months. It is the case for 2 other providers in my clinic as well. Now, this is an issue independent of COVID, of course, the need for access to our clinics, but it has been dramatically underscored by what COVID has done to access. I want to give you one example of a patient whom I dealt with last Friday. She is a single mother of 5 very young children, struggling and managing remarkably well. She is part of my Suboxone program. She has a recent history of prescription drug abuse that began with an orthopedic injury. She's doing incredibly well with the Suboxone program, as are many patients. She currently holds down one full-time job and 1 part-time job. We had an appointment Friday evening at 3:30. She called and said, I've got a 20-minute window to talk to you. I've got to get one of my kids and I've got to round up one of my caretakers. Can you get to me in that window? I couldn't. So I called her and said, can you manage a visit at 5:20? She said, yes, I'll be home then, we'll do it. We had the visit at 5:20. It was a great visit. I've spent a lot of time with this woman. We talked about her social situation, her financial situation, how she was doing with the medication, how it was going with the kids. And it was as good a visit as I would have face-to-face. This to me is an example of the flexibility in access that can be provided by virtual services, and something I would hate to see disappear. Finally, I want to talk a little bit about the financial issues involved around virtual medical care. As I mentioned already, we are struggling to keep the doors open. We are currently being paid at Medicaid. This is not the responsibility of the state, of course, but we are currently being paid for our Medicare patients approximately 50% of what we were being paid before. Now, virtual medical care allows me to be more efficient than I used to be. I used to average between 16 and 18 visits a day. I am now averaging closer to 20 and 21, but that difference is not enough to make up for the loss of our payments for Medicare. We are currently, as I said, trying to open up, but there are still going to be patients who will refuse to come in. I have a number of elderly patients who still refuse to come into the clinic. I don't think this problem is going to end when we have a COVID vaccine. It is not going to be 100% effective. There's still going to be a lot of fear about coming into the clinic. And I'm sorry to suggest that COVID is not going to be the last pandemic vaccine in the next 20 years. All in all, I'm hoping that the adjustment, the modification of the financial system around virtual visits will help us move to a more productive system that is not based on fee-for-service visits. For example, the patient I mentioned before, the single mother on my Suboxone program, she visits at least once every week or every 2 weeks with a case manager. We are not reimbursed for the case management. We have many diabetic patients who spend a lot of time with dietitians and a diabetic educator. We are not reimbursed for those visits either. So we have to make up for them in other places. If we could move to a more capitated model, we are simply paid a set fee for taking care of a certain number of people. We would simply do what is appropriate. Some people would need to come in and be seen. Some people could be managed over the telephone. Some people could be managed only with a video visit. Some people could be managed by a physician, some by a mid-level, and some by a nurse or other kind of educator. So that is where I'm hoping we are eventually moving. It's been one of the wishes of my life, which hopefully within my professional career, I still may yet see, but we're not quite there yet. So anyways, I thank you for your time.
Thank you, Dr. Golden. I think you've brought a really important perspective. And our next panelist that I would like to introduce is Dr. Anaya. Dr. Anaya is an assistant clinical professor in family medicine at the David Geffen School of Medicine at UCLA. And I'd like her to speak a little bit about underrepresented groups in some of her work. Thank you.
Thank you so much for having me. As Dr. Humphrey said, so I'm an assistant professor in the Department of Family Medicine at UCLA. I'm on the core faculty for our residency program. I have a continuity panel at both of our clinical sites. One is a UCLA health system clinic, and the other is a family medicine clinic within the LA County system of ambulatory care. I teach residents and medical students and see my own patients at both sites. And I do hospital medicine as well. My perspective is as a primary care provider and educator in both the commercial and also the safety net settings, caring for underserved and vulnerable populations. And I also work closely with the Latino Policy and Politics Initiative and the Center for the Study of Latino Health and Culture, with whom I partnered for the research on telehealth, on which I'll be able to speak on a little bit today. So, as has been mentioned, while necessary, our efforts to prevent exposure to the coronavirus really led to disruptions in patient access to primary and specialty care and most diagnostics. But telehealth really did allow for us to continue care, whether by video or by phone, and bridge the care that patients needed. With the need for minimizing risk for exposure, healthcare systems were forced to quite rapidly figure out how to effectively continue to provide patient care. And so providers really scrambled, especially in the beginning, just doing their best to shift to care for patients at a distance, scheduling the majority of their visits as either video or phone visits. So telehealth really became the primary way of delivering care for the first couple of months. But that sudden and unexpected demand for telehealth faced the dated nature of our current regulations, the absence of critical infrastructure and of reimbursement to allow that needed expansion. Temporary telehealth and remote monitoring policy changes did allow for providers to respond to the pandemic. But again, they are very much temporary and dependent on the public health emergency. Even though the use of in-person visits has incrementally increased overall, telemedicine visits still continue to make up a significant portion of clinical care. And in our own research, as well as what's been published, our overall impression is that telemedicine is here to stay. And with the pandemic getting us to embrace it, patients, providers, health systems have really begun to see the value in telemedicine and how we can actually use it to augment our care as a whole. However, an important layer that's contributing to the disruptions in access as we did shift to telehealth amidst the pandemic is that not only have patients been affected by their own lack of technology to support virtual visits, but also by their providers' lack of equipment and electronic medical record system capacity limitations. And these structural barriers are occurring on both the patient and provider sides, but they ultimately affect patients and vulnerable patients disproportionately. Unfortunately, we're already seeing the usual patterns of access disparities that tend to favor young, affluent, non-Hispanic white populations coming through in the research literature. And it seems like we're leaving behind our most vulnerable and already underserved patients, which is incredibly concerning to me as a physician. Disparities in healthcare access and quality of care for minorities have been extensively documented in the literature prior to the pandemic. And we're worsening these existing disparities if we set up our telehealth ecosystem such that only advantaged populations can use them. So while it was initially necessary, given the overnight need to adapt, the rapidly accepted models of telemedicine have actually given rise to a variety of access issues for our vulnerable patients. And as we enter what really is a new era in our healthcare delivery, not only have we got to consider how to capitalize on the progress that we've already made, so that these gains can be continued the post-public health emergency, but really we have to also begin to strategize on ways to ensure that the system doesn't leave our most vulnerable patients behind. First, of course, is technology. This means not only the physical devices, but also the software that we require patients to use in order to access our portals and virtual visits. Black and Hispanic adults remain significantly less likely than whites to own a computer or have high-speed internet at home, whereas 82% of whites report owning a desktop or laptop computer. That compares with 58%, 57% of Blacks and Hispanics owning a computer at home. And so if the telehealth systems that are employed require virtual visits or portal access to occur via computer instead of a smartphone, for example, you're physically excluding a pretty big segment of the population. Beyond having a physical device, telehealth use requires that patients also have the needed skill set in using the needed software and navigating, which we often call digital literacy. And along the same vein, despite the fact that we're increasingly using online portals to theoretically increase our patient access, there's pretty consistent evidence that racial, ethnic minorities, those for whom English is not their primary language, and patients with lower income are significantly less likely to use portal websites. However, there is data demonstrating that these populations express interest in portals. So the issue is not one of lack of interest, but rather that the telehealth systems that are just not being designed in a way that are inclusive of vulnerable populations. So this is an area that we'll need to incentivize in order to ensure that we're engaging and not leaving out these populations by our non-inclusive designs. Another way to start bridging those needs is funding tech support in the form of telehealth coordinators, for example, which can troubleshoot issues with virtual visits in real time, walk patients through signing up of portals, even just reaching out to patients who aren't engaging in telehealth ahead of time to tell them about how virtual visits could work for them, having someone literally walk them through downloading the app that they need for their video visit ahead of time, and having this type of dedicated outreach and support for patients and populations that we haven't yet been able to reach via telehealth is really going to be key for ensuring equitable access for vulnerable populations. And more broadly, really key to support the use of telehealth in an integrated way with in-person care so that physicians can really improve patient care and outcomes in the long run. We have to consider how to standardize payment structure across states, payers, generally just ensuring coverage and reimbursement, payment parity for parity in services without the option to opt out of coverage or reimbursement. We really just need to enable patients to communicate with their providers and the modalities available to them by focusing on improving their access to technology and improving reimbursement structure on the provider side. Allowing clinicians and patients to choose the care modalities that are most appropriate to their needs and also their preferences. For instances where a patient has no access to broadband or a video capable device, or where the actual clinic lack those similar devices or capacity, physicians have needed to furnish many evaluations through telephone calls. And what we can evaluate by phone, we then bring into clinic, but ensuring that parity for those services that are being rendered is really key. And then finally, as primary care doctors, we're seeing the ways in which we can really use telemedicine visits to improve continuity for patients. For example, a patient that has poorly controlled diabetes, reducing barriers to close follow-up so that we can safely up-titrate their insulin, for example, and in a way, basically just kind of hold their hand through that process, improving their treatment adherence, minimizing adverse side effects like hypoglycemia, because you're right there with them at each up-titration step. And so in this way, not only for diabetes, but other chronic conditions, we're actually improving the quality of care that we can provide and improving long-term outcomes for these chronic conditions, which will also reduce the costs of the long-term complications of these diseases, which occur when we don't have good control. I'll stop there, but hopefully some of this has helped highlight the need to address equitable access to technology, broadband for underserved communities, as well as their providers in the long term, and the importance of sufficient payment for telehealth, including telephone visits, especially as we're kind of in that preparation phase as we're building up our inclusive telehealth ecosystem that doesn't exclude our most vulnerable patients.
Thank you very much, Dr. Anaya. There are so many questions coming in, and I want to get back to some of the things you talked about, specifically about, improving access, holding their hand while you go through these things that patients feel that they're so much more connected by using telehealth a lot of times. But before we do that, I'd like to introduce our last panelist. Dr. Stoll is the Senior Medical Director for Blue Shield of California. I think she is going to bring an exceptionally unique perspective to this panel. So I'd like to have her speak for just a minute, and then let's start answering some questions.
Thank you. Well, first of all, just a huge shout out. Thank you for everyone on the panel, our practicing physicians and patients and families, and as well to the California Telehealth Policy Coalition. I think this has already been a great event. So thanks to everybody. I am Senior Medical Director at Blue Shield of California. We are one of the California health plans. We cover 4 million at least lives in California and really across all lines of business. So we commercial, both employer-based and IFP through the exchange, Medi-Cal through our Promise, Blue Shield Promise, Medicare. So we really do cover the state, and we're highly mission driven. So not for profit. And I love our mission. I just love it. It's to provide healthcare that's worthy of family and friends. And we know we're not there yet. But we spend every minute of every day trying to get there. So we're very much focused on how do we get better. So I was taking a lot of notes today, listening to the different perspectives, looking forward to bringing that into the work that I'm doing at Blue Shield. So one of our major goals is access to care, and that's been brought up throughout the conversation. If you don't have access, you sort of don't have anything. And I've been leading these efforts for a while at Blue Shield. And of course, everything changed recently. As people have discussed, whereas before telehealth was sort of out there, a possibility, and now here we are, and here it is, and we view this as just a huge opportunity. So we're actively involved in making this the way of the future. There are a lot of questions that come up related to how it's paid, how much it's paid, who can do it, the regulatory aspect of it. Wanting to be sure that our members are getting quality care. That's always top of mind for us. So is it the same quality on a phone call as in person? And how do you do things that you can't do on the phone, like give a vaccination or assure important screening? So these are all things we talk about a lot. And I think, and people have alluded to this too, I think the answer lies in really a well-orchestrated, coordinated hybrid approach. That's where we all want to get to. Using telehealth where it's important and making sure that face-to-face visit is there as well. So my specific role at Blue Shield is to lead a team of about 25 clinicians, so medical directors and nurses and social workers, and we are provider facing, work directly with the hospitals and physicians and provider groups around the state to make sure that our members are getting that high quality, affordable, excellent care. And so, and Dr. Anaya mentioned some of the provider limitations that are out there. And that's one of the areas that we're focused on as well is, what do our providers need to make this happen? What do they need from us, again, in terms of how we pay them? What do they need from technology? How can we work together? So that has been a major focus. The other thing that we look at is quality. And I mentioned that about, getting vaccines and getting screenings. And that's been something that's been, I think, concerning during all this. It's been great that telehealth is being used. I think patients like it, as we've heard. But in fact, vaccination rates are down, screening rates are down. So that gets us back to how do we assure quality? And I would also like to highlight something that Dr. Golden said as well, which is, he says he's been waiting his life for capitation. At Blue Shield as well, we believe that value-based care is the answer, whether that's capitation or something similar to that. We believe that that is what's going to drive that care that's worthy of our family and friends. And so we're always trying to drive in that direction through our HMO, ACOs, and more recently through pilots that are actually targeting individual providers with more of a prepaid approach, so that there won't be this incentive to do lots of care. It'll be an incentive to do the right care. So we're always going that direction. And I think I found with the parity that has been in place recently, it has made things a little bit complicated, because it is being paid as a one-off. It is being paid for as a particular call. You make the call, you get the reimbursement, as opposed to how do you put this together and say, we're gonna pay you to take great care of patients. So that's another thing that I'd love to hear more discussion around and learn some of your perspectives about. And then I think the final point that I'll make from the health plan perspective is around compliance. So we are pretty regulated industry, and we have a lot of standards, network adequacy standards, and these were mentioned as well. And we want to be sure that when providers are using virtual care, that it's counted, really, because otherwise it's going to get in the way of the progress of this work. So that would be my final comment on this forum, is how can we make sure that the regulatory bodies, whether they're at the state level, federal level, are counting telehealth to be what it is and what it does for members. So I'll stop there, and I really look forward to some of the questions.
Well, as the questions are rolling in, and again, there are so many of them, so we may not get to all of them, but I'd like the three panelists to first talk about one question that I think is really important. That was, what do you foresee being the biggest barrier to make telehealth reimbursable, or reimbursable telehealth a reality and the norm? Dr. Stoll, do you want to start with that one?
Sure. And the question is, what's the one thing? And, I don't know that I see a one thing on this one. But I guess I am going to say, I think it is the payment that's driving it. I mean, I think about why suddenly things flipped. It was because of the parity laws. We've been debating this for years about why people aren't using telehealth more, and then suddenly they're using it. Well, geez, it was, I really do think it was the payment, as well as really not having the choice to go in for in-person that caused it. And now that that's happened, there's an appetite for it, which is excellent. So I guess I will be the plan voice and say that I think it's getting the payment right, and getting it to incent the right things, and getting it to include quality and member experience as part of the equation.
Dr. Golden, what about you?
I think the main problem is legislation. We have, clearly, the public has a huge appetite for it. Providers have an appetite for it. We've shown it can be very successful. It needs to be regulated. It needs to be observed very carefully, but I think this ball is very much in the lap of the state legislature and the federal Congress right now.
Thank you. Dr. Anaya, do you have a thing that you think is a barrier?
I think that the main barrier had really just been that we hadn't been set up for it, right? As folks have mentioned. But I think the progress that we've made, it's important to use that to really launch us to the way forward and not take steps back, and allow for some of these changes that have been made to go away with the public health emergency.
One of the questions I find interesting too is a question asking, is it too soon to tell what percentage of visits can or should be transitioned to telehealth? Dr. Golden, you talked a little bit about the percentage that you're doing now. What percentage do you foresee going forward in the future that you'll be doing from telehealth versus in person?
On the assumption that we were reimbursed at the same rate?
Sure.
Okay, well, then I would assume that we'd probably be doing, I don't want to give a number, but we'd be doing what's appropriate. Currently we have to bring people in for things that could easily be handled in a visual presentation or a discussion, because it's the only way we can get reimbursed for our time. So I envision at least 50, I would maybe start with 50. I would envision starting with 50-50 and see which direction it goes in terms of both patients' needs. There are some people, like Mrs. Moyles was so articulate about, talking about most of hers are going to be virtual. And every now and then there's going to be one that needs to put her through the ordeal of coming in to do it face-to-face. But that will be driven by need, as opposed to, that will be driven by patient and medical need rather than by financial need.
So,
Misty, if I could add to that.
Oh, yes, please.
That's what I was going to add to that. That we asked, was on a call with a number of health center leaders like Dr. Golden, and there seemed to be a little bit of consensus that early in the pandemic, it was they were doing 70% telehealth and 30% in person, and that that the evolution might take them to the reverse of that, right? That once in person opens up more, you might see something that is more like 70% in person and 30% telehealth. Of course, there's no exact number, as Dr. Golden said. And I think important just to realize that this is an evolution as we learn how to do telehealth across different disciplines. This is something that you're studying, Dr. Humphreys, as we reach more patients, as Dr. Anaya has mentioned, in terms of getting broadband out to more patients, in terms of integrating language access along with telehealth. We can reach more patients. And then finally, I would just say it varies, of course, a lot by the discipline. So I was mentioning what some clinic leaders in primary care said. We find that in mental health, so much mental health can be provided via telehealth, via phone and video. And that has just been a boon. Even before the pandemic, we saw a movement in that arena. And since the pandemic, really just an explosion of telehealth. And then, but there are other, obviously there are other specialties, dermatology and endocrinology and others that are more, I think, more easier to integrate telehealth into that practice, and then others that are more difficult.
No, I think what you said was really important. And, we have a myth busting sheet that is in the packet of information. And one of the big things that people talk about is there will be overutilization, but patients like to come in. And if you look at all of the data and all of the studies, it shows that patients actually do most of the time prefer to have an inpatient or an in-person visit. So I think where there is this fear that it's going to just go crazy, it's going to be appropriate because most patients still like to come in. So I want to try to combine the barrier question that I asked before with the other questions and ask you, Ginger, about something, because one of the barriers I see is actually image sharing or data sharing amongst proprietary institutions. And you mentioned earlier that you sometimes have to come 5 hours to get tests, MRI, X-ray, things like that. How often do you think those tests could be done somewhere closer to where you live? And if there was adequate image sharing through a legislative process or a mandate actually between institutions, that even that could save you time.
That would save me time if we had adequate imaging in my area. Right now, the imaging in my area is not the quality that it is if I travel to UC Davis. So for me, it's worth it to drive to UC Davis to get the quality imaging for my child. I do just love having the telehealth to get the results of that imaging. If we had a place up here that had the quality imaging, I could go into Medford. They have great imaging. That's a lot closer than going to UC Davis. If that was an option, I would love to do that for imaging and then have that sent down to my doctors at UC Davis, because I want to keep my doctors. But the imaging is definitely a big issue. If that could be transferred, that would be wonderful, and that would save a lot. But I wanted to touch on, I love going into the doctor locally. We have a great local doctor that I do take her to frequently here. My big one is the long travel, is the telehealth. I typically do not use telehealth for my really local visits. We did when COVID first started because we had no options. I do know that my mother uses me and my technology experience to get her onto her Zoom calls for her telemed appointments. So I know for the elderly that can be an issue to access.
So Dr. Golden, I want to go back to this about the elderly and using phone versus video visits. You're using, where you live, you have a real difficult time with broadband, like you mentioned. So can you talk a little bit more about the use of phone visits and the reimbursement there?
Sure. I think one of the concerns that I've heard expressed by some of our sympathetic legislators is they're afraid that this is an invitation to fraud, that it's too easy to do a telephone call and we'll be charging for what we used to do as a brief telephone call as if it is a complete visit. My phone calls and my phone visits are very different animals. When I have a visit, it is on the schedule in advance. We scrub our visits, which means that a medical assistant goes through the chart before the visit to address not only why they're there that day, what are the relevant labs for that visit, the relative imaging for that visit, but what healthcare maintenance issues need to be addressed during this visit that they are up for. So we address what currently needs to be taken care of, what needs to be taken care of in the future. We go through, we review all the medications, we review recent communication, we review allergies. In a phone call, you don't do that. In a phone call, you might address one specific question. You might give a lab result, you might give an imaging result, you might be checking up on somebody because you're concerned about them, or simply answering a question from a patient. It's very clear how different these two phenomena are. So I don't think it's a real issue. And I understand how one could dip into a fraudulent zone with this, but that's very easy to manage and very easy to monitor with even minimal kinds of guidelines.
I think that is something also that brings in the idea of quality. And so, Dr. Stoll, I'd like to ask you if you could touch base, and also Mr. Perrone, on what you think are some of the measures and metrics that we should be using for telehealth quality. And do those need to be different for telehealth versus in-person care? Dr. Stoll, do you want to start?
I mean, I think it would be hard to kind of pull that out and say, this is what we're expecting of telemedicine, this is what we're expecting of in-person. I think rather thinking of it as bundled and looking at the care trajectory for a particular patient, and did they get what they needed through the course of the year? Did they get their screenings? Did they get their vaccinations through the course of the year? And then just recognizing that they used both. So to me, it's just, I guess my answer is no, I don't think there's anything particular. I mean, I think there's some certain approaches that might be different on with telemedicine. So, for example, for colorectal screening, it's a great opportunity to use telemedicine. You can talk to the patient about it, and then you can mail them a kit. They don't have to come in at all. So that's a great one. And again, figuring out those hybrid approaches. So you counsel the patients about the parents about the childhood vaccines, and then they come in and they can find a place to get it done. So I see it as the same measures, because I think these are the critical measures, but just taking into account that there'll be perhaps different workflows to get us there. The other thing I would want to mention too as well, that I realized we hadn't talked about quite yet, is just we've talked about the sort of brick and mortar providers and those on the call today who are now expanding into telehealth, but we also have all these telehealth companies out there who started out as telehealth and now are thinking about how do we expand ourselves. So we use Teladoc, Blue Shield does, as our vendor, and we also have a lot of home-based providers like Heal and Landmark, and they are also now in the telemedicine space as a result of COVID. So one quality issue is in this environment where you might have a lot of different providers touching a member through telehealth. How do we orchestrate it? How do we sync it? How do we make sure they're not getting duplication? How do we make sure they're not falling through the cracks? So to me, that coordination piece is another one that we're really busy tackling.
Chris, do you have
And
some?
I would just add, I think I largely agree. I would just add that NTQA is certainly doing a lot of work with a number of advisory committees right now in terms of adapting some of the current quality measures under HEDIS, the quality measures that they use for managed care, and adapting those to be inclusive of telehealth. So that's one area, and I think probably the consumer assessment questions, probably the same need to happen. There probably are some specific, I mean, I think we do want to know what patients have access to, and there might be a number of ways to measure that. It could be, for example, in when you start with a video visit, how many have to transition over to a phone visit because the technology just isn't there to support it. So there's probably a few of those things just to make sure that that, you know, as access is part of the quality equation, and to make sure that, again, as Dr. Naya said so well, that we are reaching all of our Californians with telehealth.
Dr. Naya, I wanted to talk to you specifically because you brought up, you know, the underrepresented minorities or some of the groups that are sometimes limited in their use. How do we use interpreting services, either in the phone visits or in the video visits? How has your organization kind of included that?
Yeah, so a big issue in California is access for limited English proficiency populations. You know, in California, nearly 44% of the population speaks a language other than English at home. And but after English, Spanish is the most frequently spoken language in the United States and in California. And you know, as has been like brought up, these patients face systems of care that are designed around the provision of care for English-speaking patients. And, you know, with telehealth systems, you know, unfortunately so far has not been able to accommodate as well, and more so on the like website, for example. So, you know, the actual incorporation of interpreter services over virtual or phone visits is definitely done, you know, both at our county and our UCLA health side. And, you know, similar to, so instead of just bringing in a actual interpreter into the visit, you know, you do this by phone. And so you have basically like a three-way call if you're doing it by phone or even also during video visits. But for, you know, on the kind of greater telehealth system side, there was a recent study of 170 hospitals across the US, and only one of those hospital websites clearly noted interpreter options for virtual visits, and most hospitals require navigation in English. And so this is definitely a big issue and something that we just kind of need to continue to work on.
Ginger, you brought up something that I thought was very interesting, is you are taking care of your child through virtual care, but you're also helping your mother, you said. So you have this span of the child and the older adult managing telehealth and telemedicine. So I'd like you to bring in that perspective a little bit and tell me what other things you think that families need in order to use telehealth more effectively.
Access, at least for the rural area, has been the biggest barrier, I believe. My mom doesn't understand. She doesn't have a computer. She does not have internet access in her home. So she comes to my house for her Wi-Fi. She doesn't know how to download the apps. She's tried to walk through it with the nurses at the office over the phone. she just doesn't understand it. She's 80 years old. So I've helped her with that. But she doesn't have connective ability. I don't know. I know that it's available without Wi-Fi. I have not yet been able to explain that to her effectively. I've done video. I did a telehealth conference the other day when school just started because of COVID with my daughter in the parking lot at the school, because it was easy. And it was a doctor at UC Davis, and she was wonderful. We were only needed to pull her out for a few minutes, and I sent her back to class, and I finished the conversation with the doctor. It was great. She got to talk to her and do what she needed to do. But I did that via, I didn't have to have Wi-Fi. But I had that access off my phone. And a lot of people don't necessarily have a smartphone. My husband had a telehealth, and he does not have a smartphone. He loves his flip phone. He's 60 years old, and he's not going to switch from his flip phone. I think there's a lot of people that are going to have difficulty with the technology. The older generation is going to have difficulty with the technology. And in this rural area, the connectivity is a real problem. A lot of people don't even have Wi-Fi access out here.
So myself and Dr. Anaya are in urban areas at places that really had telehealth kind of already built up. But one of the questions that came in was about, as providers, what has been the most effective ways to learn about doing telehealth better, and what's missing in this space? First, I'd like to say that the center or the coalition has some amazing tips and fact sheets. But Dr. Golden, how did you ramp up in your center from doing so little telehealth to going to kind of full stream? And can you talk a little bit about where you got the resources and your information?
Yeah, well, we did it because we had no choice. Fortunately, we had just purchased 6 iPads. I can't remember what, we got them from a grant, and I can't remember what they were actually purchased for, but purely serendipitously, we had access to them for doing video. Otherwise, we would not have been able to do any video calls. And my sister clinic, MCHC in Ukiah, which is much larger than ours and has much greater resources, have been unable to do any substantial number of video calls because as soon as COVID broke out, there are no more video cameras available. And there was a privacy issue using our smartphones. So they've been unable to do any. I think we just scrambled, went online, looked, talked to colleagues, asked what worked. I don't know whether we had direct communication with the coalition or not. But I have a very skillful executive director and operations director who just got on it and figured it out, which is what we tend to do at our clinic.
I think we tend to do that even at the academic institutions. Sometimes I'm just going to figure it out and it's going to work great. Mm-hmm. So we've had so many discussions and so many questions that we didn't get to, and I'm sorry about that, but I'd like to bring back Mei Kwong to kind of close out the session.
Thank you, Dr. Humphreys, and thank you to all of our panelists for this very informative discussion today. So I want to thank also our attendees for showing up and listening in to these great speakers. Just a couple of things for you. If we could just have the last slides up, please. There we go. We do ask if you would fill out an evaluation that we have here. You will find that in the handouts. Also, their link was provided in the chat as well. Next slide. Once again, we thank our generous sponsor for today's webinar, the California Healthcare Foundation, ARP California, and Buchleiter. Next slide, please. Please know that this webinar is being recorded and it will be posted on California Telehealth Policy Coalition webpage on the CCHP website. There you'll also find a copy of the PowerPoint deck as well as the handouts that have been mentioned a couple of times during this webinar. We also have a link of resources in the handouts, so you'll find things such as Dr. Anaya's report that she mentioned as well as links to all of our speakers' homepages as well. Next slide, please. And that is it. So I just wanted to thank everyone again. Thank you again to our speakers, to our generous sponsors, and for the attendees for showing up today and listening to our webinar. Wish you all a great day, stay safe, and have a terrific week. Bye.